The title of this presentation is Tinnitus Assessment and Management is Primary Care Audiology. As you probably can gather from the title, it's my opinion, and I will present evidence in support of this opinion, that every audiologist should be prepared to evaluate patients for tinnitus and to provide at least some general management recommendations to help these patients. Based on my clinical experience with patients coming in with bothersome tinnitus as their chief complaint, this is a very feasible possible objective. That is, evaluating a patient who's coming in with a complaint of tinnitus and providing management that will be successful in over 80% of the patients. In other words, most audiologists don't need to immediately refer a patient with bothersome tinnitus to some so-called tinnitus expert. Most audiologists can provide the services that the patient needs without referring them on to a specialist. As you may know, I've been a professor at many universities, and at this point in my career, I am teaching online at a number of universities, as you see here in this slide. I want to point out that I'm always available by email. The address is at the bottom of the slide, the first slide. And I also have a website, audiologyworld.net, and many of my presentations and articles and other information you might find of interest is on that website. So I encourage you to check it out. Now, I'm keeping a close eye on the clock so that we don't run over 1 hour. And that means we're going to move through these topics relatively quickly. You will have access to this PowerPoint presentation, a PDF version, and I will also point out that on my website I have some articles on this topic that you could consult for more detailed information. Let's begin with the very first topic here, the first bulleted item. Tinnitus is a symptom, not a disease. Well, that is true. Tinnitus is not a disease. Patients will come in to see you and they'll say, I've got this ringing in my ear. I want you to give me some treatment. Is there a pill for this? And the very first thing you always need to stress to patients is this is not a disease process. Tinnitus can't be cured with a pill. It is a symptom of something that's affecting the auditory system in almost all cases. And your first goal as an audiologist is to find out what is causing this symptom. What is this symptom representing? What etiology or what disorder? Now, tinnitus, when it bothers someone, is a disorder, so we have to distinguish between the terms disorder and disease, but it's not a disease. It's not a disease in and of itself. It is a perception of sound. Tinnitus is a perception of sound that is real. It's actually a real sound to the person, and parts of the auditory system that mediate hearing, parts of the auditory system involved in hearing, actually are activated when a person has tinnitus. And we could talk about that at length. It's definitely been documented many times on MRI. So one of my first messages to a patient who comes in who may have been kind of ignored or not really paid close attention to by their primary care physician or maybe even an otolaryngologist, my first message to the patient is this is real. You are hearing those sounds just like you would hear a telephone ringing or some other sound that's external. It's just that your auditory system is actually generating the sound that you're hearing. It's generating the perception of the sound. So it's a phantom auditory perception in that there's no external stimulus, but that doesn't mean it's make-believe, doesn't mean it's quote-unquote in your head or just in your head. That is very disconcerting to a patient to be told this tinnitus is not real, because it is real to them. And of course, because tinnitus is a symptom and not a disease, one of our first goals it must always be to find out if tinnitus is a symptom of a very serious disease, something that might be medically or surgically treatable. So I always start out with every patient, regardless of their level of education or regardless of how much they know about tinnitus, I start out with that type of simple explanation. I want to validate this problem. If I validate that they really have tinnitus and I'm convinced that they have it, assuming I am convinced. And we won't get into medical legal issues, but there are certainly patients who will say they have tinnitus who don't. But they're very rare patients. You don't see them very often. The average patient that you will see in a clinic is convinced they have tinnitus, and you need to validate that. And based on your findings, not just taking their statement or their complaint at face value, you're going to validate that they really have tinnitus, or you're quite sure they do. And that is a great step toward management of the patient. Now, there are many types of tinnitus sounds. In fact, you might say that there are as many types of tinnitus sounds as there are patients with tinnitus. And this has been demonstrated for over 70 years. Ever since the 1950s, people have recognized that patients who try to describe the sounds they're hearing come up with all kinds of different descriptions. Now, they're never adequate descriptions. In other words, it would be like if somebody said, "What did that uh, dessert taste like?" or "What did that beer taste like?" or exactly what did that sunset look like? Whenever there's some kind of sensory experience, our words are really inadequate to describe it. You can kind of give people an idea. You can rule out certain tastes or certain visual sensations, but you can't really replicate or describe in great detail exactly what a person's hearing so that you would know exactly what they were hearing. It's impossible. So everybody who hears what they describe as a ringing sound is not hearing the same sound. In fact, most people, it's not a single frequency that they're hearing. It's a very complex sound. And ringing is kind of the closest uh, description that comes to it. Ringing, by the way, is that word ringing is derived from the Latin, or I should say the word tinnitus is derived from the Latin word for ringing, like a bell ringing. So that's a very common sound. I've got a high-pitched ringing sound. I've had it for many, many years. And I can tell it's really kind of a combination between ringing and crickets because there are multiple sounds. And as soon as I start talking about tinnitus or lecturing about it, like I am now, my tinnitus literally becomes so loud that I can't ignore it. It's really quite amazing. But there are many other sounds. And one of the first points that I make to patients who come in with a description of a certain type of sound is that the actual sound that they hear does not have any diagnostic importance. Now, what do I mean by that? What I mean is that if they hear a ringing sound, that doesn't mean it's more serious or more severe or more concerning than a humming sound or a pulsing sound or a running water sound. That sounds that they hear are a reflection of problems in their hearing system, their auditory system, but they're not necessarily related to the diagnosis or what this symptom of tinnitus is actually reflecting. Now, why is that important? Well, some patients are so concerned, so worried because they've heard that a certain sound is associated with really bad problems like a tumor or a stroke, and that's the sound they have. So I immediately point out that some patients hear more than one sound, some people, and that these sounds are very normal. If you get a normal hearing person who has no problems with their ears and they've never seen an ear doctor, and you put them in a really, really quiet environment, like a very quiet sound booth, and you plug up their ears with earplugs so that they can't hear any external sounds, or you get them to lie down in bed and it's very, very quiet. Most people, most normal hearing people, will perceive tinnitus. So there's no diagnostic significance to the type of tinnitus. And that's a very important point to stress to people. And when somebody says, "Oh, I've got ringing sounds and I've heard that's the worst kind of tinnitus and that means I'm going to lose my hearing," I'll say, I've got some good news for you. Ringing sounds are the most common tinnitus sound. And when we work with people who have ringing sounds, we can help them. We can get them to the point where they're not concerned about these sounds anymore, where they barely pay attention to them, and where the ringing sound in their ears is no different than a phone ringing or some other sound that they're hearing. So don't be concerned that you have ringing sounds. There's nothing all that serious about ringing sounds in compared to some of these other sounds. Now, patients with bothersome tinnitus are often very miserable. and they're not the people that they used to be. You'll hear spouses say, "Oh, my husband is he's not. He used to be happy-go-lucky and a smile on his face, and now he's miserable and he's irritated and he's short-tempered and he's making the rest of us really upset. And the kids are upset, and everybody he works with is upset, and he's just moping around." So tinnitus can have an incredible impact on someone's lifestyle and their quality of life, and that's why we need to take it seriously. Um, Now, among all of these different psychosocial consequences of tinnitus that you see listed here, these kind of complaints and characteristics, which are very common. Obviously, many patients have almost all of these on the list. Um, of them, the one that's probably the most serious is sleeping problems. And so if you have only 20 seconds or 15 seconds to learn as much as you can learn about a patient with bothersome tinnitus, the one question I would ask them is this: do the sounds that you're hearing in your ears keep you from falling asleep, or uh, keep you awake if you happen to hear them around bedtime? And if they say yes, yes, one of my main problems is I no longer can get a good night's sleep, and I'm constantly tired, constantly dragging around. That's a vicious circle. And when the sleeping problems begin because of tinnitus, that enhances the sounds of the tinnitus, makes them seem much worse, much louder, and then of course that makes them stay awake more, not get such good sleep, and there's the vicious circle. So I acknowledge these problems, and when a person comes in and I've read the history for them, very often I'll say, you probably are having a little trouble concentrating when you read or when you're working on something that requires your concentration. And I bet you're a little more irritated than you used to be. And very often patients will say, wow, you must really understand tinnitus, because that's true. That's exactly the way I'm feeling. And if the spouse is in the room when you're counseling, or the family members, they'll begin to trust you as well, because they'll realize here's somebody that understands the kind of problems that we're dealing with. So I get right into all of this with patients. And again, I'm validating their problems, and I'm showing them that I understand them and I understand how serious they are. But I also am very positive. I'll say, at this point, you probably figure, you've actually said to me it's hopeless. Almost like life is not worth living, and you don't think you'll ever get better, and you've got the most severe case of tinnitus that anybody's ever had. But let me tell you, from my experience, we can turn this around pretty quickly. We can get you to the point where you're not responding in these ways or reacting in these ways to tinnitus, and where these problems will go away. So I want to make sure that patients understand that we know what we're talking about when we're evaluating them, and that we have experience in improving the quality of life in people with very bothersome tinnitus. Okay, we're going to move right on now to some of the mechanisms of tinnitus, the physiology or pathophysiology, and some of the anatomy that's involved. And I'm going to have to go through this very quickly, because otherwise we'll never finish everything in an hour. But I'll give you some references on this topic so you can read a little bit more if you're interested in it. It is important. You have to understand why people perceive tinnitus, and you've got to be able to explain it, the mechanisms, and explain the problem to patients in a simple way. That's critical to their management. If you can convey to a patient why they have tinnitus and that it is a physiological problem, it's not psychological, not entirely at least, then that's another big step toward effectively managing the patient. If you go to a doctor and they explain exactly why you're having certain symptoms, you always walk out much more relieved, and feeling actually better, even if the doctor hasn't yet done anything to actually treat the problem. Well, almost all cases of tinnitus, and I say almost because there's never, you can never say, be absolute about anything, but almost all cases of tinnitus start in the cochlea, the inner ear, with hair cell damage. And we're going to talk about hearing assessment of patients with bothersome tinnitus in a moment, and I'm going to stress that DPOAEs, distortion product OAEs, are very, very important, and that's because we need to document whether the hair cells are working normally. Now, in my career, I've seen thousands, really literally thousands and thousands of patients with tinnitus, and in that time, I've seen only a handful of patients who had perfectly normal cochlear function. There are some patients with central tinnitus, usually related to a head injury, sometimes related to anesthesia or some central mechanism, but those are very rare. The average patient you will see will have hair cell damage, and so you want to document that. And when the hair cells are damaged, these are theories that have been proven with animal research and to some extent with human research. There's an imbalance between inner and outer hair cell function. There's less activation of the auditory nerve because of hair cell damage, and the nerves therefore need to be create a little amplification in order to increase the information coming in from a damaged cochlea. Less activation is occurring because of the damaged hair cells, so the neural system begins to boost that up a little bit, increase the gain to get as much stimulation as possible, and all of that can lead to tinnitus. Now, you can also have auditory nerve dysfunction that's related to tinnitus, even in a person who doesn't have an acoustic tumor or any other neural dysfunction. That's because of the deafferentation of the nerve by the damaged hair cells. But then you can also have tinnitus due to a tumor pressing or anything pressing on the auditory nerve. It may be a vascular loop, it may be some other type of, it may not be an acoustic tumor, it could be anything pressing on the auditory nerve that it could even be due to trauma that affects the auditory nerve. So the auditory nerve's got to be involved in tinnitus because that's the way the in, the stimulation or inappropriate stimulation of the central nervous system can get from the ear to the brain. Now, the middle ear doesn't cause tinnitus, but it definitely can be involved. I've had patients who have had a sudden onset of tinnitus associated with otitis media, or with getting an earplug stuck in their ear, or even just having some congestion, a cold, and going up in an airplane or going up a steep hill even. And that's when they started noticing the tinnitus, and then their brain kind of overreacted, thought that there was some serious problem, that they might lose their hearing, that it was a symptom of a disease, and then, of course, the tinnitus becomes very bothersome. So one of my policies is always to evaluate the middle ear very carefully, audiologically and by history, and then to make sure I'm managing or referring patient for management of any problem that might affect the middle ear, including allergies and sinusitis. Now, I mentioned that I would point you in the direction of a couple of references for the mechanisms of tinnitus, and here's a quite recent one, Ryan and Bauer, The Neuroscience of Tinnitus. And so they review all that is known up through 2016 and talk about many of the things that I've been discussing right here. So the more you know about, and you can find chapters, you can find articles, review articles on the mechanisms of tinnitus in addition to this one. But I would encourage you to check them out. Now, sooner or later, the brain's got to be involved in a patient with bothersome tinnitus. They've got to be perceiving the tinnitus. So right now, my brain is being activated by my tinnitus, and I'm realizing I have it. I'm thinking about it a lot because I'm talking about tinnitus. And so with any patient who hears tinnitus, the primary auditory cortex is being activated, not by an external sound, but by this internal neural activation related to the tinnitus. And that's normal, and there's nothing wrong with that. And if a patient's auditory system, their primary auditory cortex, is actively involved in tinnitus, that doesn't necessarily mean they're going to be bothered by the tinnitus. Many people, like me, recognize it's not a symptom of a disease or pathology, and I will just pretty much ignore it or habituate to it. It becomes subconscious. But there are two non-traditional parts of the auditory system that very often, almost always, are involved in patients with bothersome tinnitus. One is the limbic system, which it's a very complex part of the nervous system, and it involved the emotional response to sound. And the other is the autonomic nervous system, which controls the fight or flight reaction to some very what is perceived as a dangerous sensation or signal, like a sound that nobody knows what, the patient doesn't know what it's all about. It may very well indicate that something very bad is going to happen, and so therefore they develop this fight or flight response. There also are frontal regions and prefrontal regions of the brain that are involved in mediating the response to tinnitus, and also determining whether it becomes a real concern or is pretty much ignored. So you've got the traditional auditory pathways, but almost every patient with bothersome tinnitus has activation in these non-traditional auditory regions. And this has been described in great detail in recent years. So I tell patients this, the mechanisms of tinnitus are extremely well studied. 30 years ago we knew almost nothing about it. Now we know a tremendous amount. There are people who are devoting their entire research careers to studying tinnitus. And we know that this gating mechanism, this turning on and turning off, is critical. So if the auditory cortex alone is involved, but these other secondary areas, the limbic system, the amygdala, the frontal areas, the prefrontal cortex, if they're not involved, then a person's just hearing the tinnitus sound like any other sound. But when these non-traditional areas are involved, the tinnitus sound takes on a whole different meaning. It's much more concerning. It becomes a big part of their life. In fact, it may be the only focus in their life. So we've got to somehow break this connection between the primary auditory cortex and these non-traditional auditory areas. The term compensated tinnitus, which is shown in the upper left-hand corner here, section A, is what most of us have who hear tinnitus. And we compensate for it. We understand that it's not a real issue, and most of the time we're not even aware of it. Down below you have the tinnitus as a disorder, where all of these areas are involved and the person basically cannot stop hearing the tinnitus. All right, now we're going to move right into tinnitus assessment. And it is quick and it is simple. If you can perform a comprehensive audiological assessment, if you have the equipment, a diagnostic audiometer, and OAE equipment, and oral emittance or middle ear equipment, middle ear analysis equipment, you've got everything you need to perform the assessment. Now, you want to follow clinical practice guidelines. You want to practice standard of care, and it's very simple to do that. There are several sets of guidelines. Many years ago, I was on a task force that developed these guidelines, along with several other audiologists whose names you'd recognize, Richard Tyler, and Robert Sweeto, and others. And you can find these on the AAA website. Now, these are a little dated, and we know much more about tinnitus than we did then, but they're still very valid, so you want to follow them. And these guidelines state that this is definitely within our scope of practice to assess and manage patients, and it also talks about various treatment options. A newer set of guidelines was put together by another task force consisting mostly of otolaryngologists, but some audiologists, and they're quite a bit more recent, just the last few years, and I encourage you to check them out. You can easily find these guidelines with a Google search. One of the benefits of this set of guidelines, it really talks a lot about the medical management of tinnitus, and also talks a lot about the inventories that are available for evaluating the impact of tinnitus on quality of life. Now, the audiologic analysis or assessment guideline in these guidelines is, in my opinion, could be improved. For example, there's a big emphasis on pure tone audiometry with almost no emphasis on OAEs. And in my experience, it should be just the other way around. The OAEs are one of the most important tools for the assessing a patient with tinnitus, whereas pure tone audiometry may or may not contribute. In other words, you could have a patient with very bothersome tinnitus who has a normal audiogram, and yet they have very abnormal OAEs. And the OAEs are abnormal in the same frequency region where they perceive the tinnitus. So these guidelines are all good, but none of them are perfect. One of the first steps in assessing a patient with tinnitus is to use a specialized questionnaire for people with bothersome tinnitus. And I'll be happy to send this to you. You can find them online, though. Much of this questionnaire is from a workshop that I attended way back in 1997 that was put on by Pavel Jostrobov, and we'll talk more about him later. But Dr. Jostrobov is not an audiologist. He's a hearing scientist, a researcher. But he had a clinic first at University of Maryland Medical School, then at Emory, and he's been active in tinnitus for a good solid 30 plus years. And so this questionnaire is very, very detailed, 27 questions specifically for tinnitus. And it really gives you a pretty good understanding of how the tinnitus is affecting a person when you have them complete this. And I'd prefer to have patients complete these questionnaires and the history forms, the inventories, before I even see them. Ideally, I'd like to have the results in my hand before I go out and see the patient or greet the patient. So these are more questions on this history form. How does the tinnitus interfere with their day-to-day activities? Do they feel down in the dumps or kind of discouraged, or are they depressed because of it? Are they taking any medications? And if so, we review whether the medications might be related to the perception of tinnitus. Of course, I want to know if there's a lawsuit involved, because those patients very often are not interested in treatment and they have actually a very legitimate reason for allowing their tinnitus to become a real persistent problem, because they're hoping to get some money from somebody for the tinnitus. And then I want to make sure that I understand whether the patient thinks their tinnitus is a problem or their hearing loss is a problem, the biggest problem, or hyperacusis. And so I usually try to get them to rank their concern for these three problems, and I kind of help them to come up with an accurate ranking. Now, after the history, we want to go straight into the audiologic assessment. And I'm not going to go into this in detail at all. These are pretty straightforward. I'm not going to describe the different procedures. You already know quite a bit about them. So first otoscopy, then emittance measurements. The big difference with emittance measurements in a patient with tinnitus is I almost never record acoustic reflexes. Now, I'm a big proponent of acoustic reflexes, and for most patients I would use apply acoustic reflex measurement quickly, but not in these patients, because many of them have hyperacusis. They have decreased tolerance to loud sounds, and I don't want to exacerbate or worsen their problems. And most of these patients, particularly those with real bothersome tinnitus, are going to get a complete otologic assessment. So if there's any concern about a retrocochlear abnormality or ear disease, the otolaryngologist or the otologist will take care of that. Many of these patients will end up getting an MRI. So there's just no diagnostic value in recording acoustic reflexes. Now, if a patient has pulsatile tinnitus, where they describe a tinnitus that comes and goes very rapidly, then I will perform tympanometry, and I'll always do that, of course, with all the patients, because I want to rule out middle or confirm middle ear problems. But then I'll also record acoustic reflex decay, but not with a stimulus. I'll do it at the lowest intensity the equipment will allow me to present, because I want to look to see if in the tracing, if there's any changes in impedance associated with a pulsing of a blood vessel that's running through the middle ear. We won't get into that in any more detail, but I just want to say that in most cases, acoustic reflexes are not a good idea for a patient with bothersome tinnitus, but there is one exception to that, where you're not presenting a stimulus for the reflex, but you are actually using the reflex mode of your device. OAEs, very important. Try to get information from 500 hertz to the highest possible frequency, at least 5 or 6 frequencies per octave, maybe higher. You want to get as much information on cochlear function, outer hair cell function as you possibly can. Now, here's a little trick I developed over the years. I started using DPOAEs with tinnitus patients at the very same time I started seeing tinnitus patients in 1997. We just at that point had our OAE devices for 2 or 3 years, and I found that sometimes patients would walk away from the OAE testing saying, you know, I finally heard that you were able to produce the same sound of tinnitus that I hear. So I started asking them about it, and I realized that as we sweat through these many frequencies, dozens and dozens of frequencies during OAE testing, sometimes we happen to present a frequency that was very closely related to the frequency region of the patient's tinnitus. And it might often be between the octave frequencies, so you can never get that information from an audiometer. So now I ask the patient if they ever hear the sound, the pitch of the sound that they always hear as tinnitus while I'm doing the test, just raise their hand or raise their finger. I don't want them to say anything, because that'll ruin the OAE measurements. And very often that gives you a rather precise pitch measurement, which you're going to later do with the audiometer. You're getting the person to match the pitch of their tinnitus. So again, OAEs, extremely valuable. With OAEs, I can almost always determine whether there's normal or abnormal cochlear function. Now I realize, of course, that OAEs are only being produced by the outer hair cells, but you'll never find, almost never find, in a typical patient with noise exposure or who's aging or with any typical etiology for a sensory neural hearing loss, you almost never find a patient who's got perfectly normal outer hair cells and then abnormal inner hair cells. The outer hair cells are more delicate, they're more sensitive, they're almost always the first structure to be damaged in the cochlea if there's anything that's affecting the cochlea. Ototoxic drugs are another good example. So if you've got a patient coming in for tinnitus, you can almost always document cochlear dysfunction by quickly performing OAEs. And the OAEs give you information you get that you don't get from pure tone audiometry. Many audiologists have the misconception that the audiogram is the best test of hearing. Well, I could go on for hours about the weaknesses of pure tone audiometry. It's a horrible hearing test, really. And in terms of detecting cochlear dysfunction, OAEs are far more sensitive. They're far superior. So these are data from a number of patients that I've seen over the years, hundreds and hundreds of patients, where I've collected OAE data, I have audiogram, of course, and we compare the percentage of normal findings, and it's always higher for the audiogram. In fact, it is not uncommon to have a patient with tinnitus that's driving them crazy, and yet their audiogram is perfectly normal. And they may have been told by their doctor, family doctor, and even by an otolaryngologist or even another audiologist, oh, there's nothing wrong with your hearing. You're just fine. This is all in your head. You're just going to have to learn to live with it. And they're kind of given the impression that people don't take them seriously, the patient is, and that people think they're crazy. But then I come along with OAEs and I say, you really have a problem in your ear. You can hear faint sounds, these simplest of all sounds, these pure tones, without any problem, but you really don't have normal ears. We did a sophisticated test of how well your ear is working, and it shows that there's some delicate little hair cells that aren't working well. Now, the good news is this is not a disease or a pathology. And the other good news is that now we know where your tinnitus is coming from. That can change a patient's attitude almost instantly. If you want more information on the use of OAEs clinically and in particular in tinnitus and hyperacusis, I would recommend the book that I co-authored. This is the most recent version, 2018, with my colleague at Northwestern University, Sumit Dar. And this is available from Plural Publishing. Okay, now moving on with the diagnostic hearing assessment, it doesn't take long. It takes longer to talk about it than it does to do it. Typically not more than 30 minutes. Pure tone audiometry in addition to oral emittance, tympanometry in addition to OAEs. Pure tone audiometry is many frequencies as you can do, above 2,000 hertz, certainly 3 and 6,000 hertz. Bone conduction, rarely do you need to do it. Very often the patient's already seen an otolaryngologist. They don't have any middle ear complaints. They've got normal tympanograms. Their OAEs are normal in the low frequencies. You get nothing out of doing bone conduction, so you don't do it. And you don't bill for it. You don't use the comprehensive audio CPT code. You bill, unbundle, and you bill for air conduction alone and everything else that you're doing. Speech audiometry is important, of course, but I only use the single syllable words, PB words, that are ranked in difficulty in every list from 1 to 25. You can get these from several in several forms. You can get NU6, W22. And so if I've presented 10 words and the person's got all 10 of them right, I stop after 10 words because I know that the words after the 10th word are always going to be much easier. Now, some of these patients will complain they're having a lot of trouble with speech perception and noise. And I will always do speech perception and noise tests on every patient where I think it's indicated. Because the more thoroughly you evaluate the patient's hearing, and the more convinced they are that you're doing a very, very good job, and the more you're describing with your findings the problems they're having, the more they're going to trust you. So speech perception and noise is an important part of most tests. Now, we've got to evaluate the tinnitus itself, and this is called psychoacoustic assessment because it's not It's not an objective test like OAEs. There is a lot of judgment involved. But it's interesting. Most patients will say, oh, I'm not sure I'm going to be able to do this. And they do a very good job. You find their threshold for white noise, just the lowest level of white noise that they can perceive. They're just pressing the button to the white noise that you're presenting just like you would present a pure tone. Then you estimate the tinnitus pitch by using the audiometer. I already mentioned using OAEs as well. And here you're just trying to, you tell the patient, you're trying to get into the ballpark of where your tinnitus frequency is, the pitch of your tinnitus. Usually it's frequencies above 3,000 hertz, but we try to get as creative as we can to narrow it down. And sometimes I've used a pure tone and mixed it in with the narrowband noise to get a more natural tinnitus sound, almost a cricket type sound. But all we're trying to do here is find out, is the tinnitus between 3 and 4,000 hertz? Is it 8,000 hertz or above? Is it lower frequency, mid frequency? And that'll help us as we develop our management strategy. So it doesn't have to be all that precise. We also definitely want to assess tinnitus uh, loudness. And how do we do this? Well, it's been well described. And I always do this with the ear that the person's hearing the tinnitus in. So when I'm measuring tinnitus loudness, I asked, now are you hearing the tinnitus in the right ear? Yep, I am. And it's that high pitch ringing? Yep. Okay, we're going to take the frequency, the pitch that we found is closely matched to your tinnitus, and we're going to find out how loud your tinnitus is. So I start out below the person's threshold for that frequency. So let's say it's 3,000 hertz. Let's say their threshold at 3,000 hertz is 30 dB. I'll start at 25 or 26 dB. I'll use 1 or 2 dB steps, and I'll gradually increase the tone I'm presenting to their ear until they say, oh, that's about the same loudness as the tinnitus I'm hearing. And very often, in fact, in almost all cases, the tinnitus that a person's perceiving is less than 10 decibels above their threshold for that sound. So even though they say the sound is extremely loud, in fact, they're perceiving it almost like the drop of a pin. Sometimes they'll hear the tinnitus and say, oh, that's how loud my tinnitus is, when you're exactly at their threshold for that frequency. Then I find out, well, how much white noise, broadband noise, does it take to cover up their tinnitus? How much sound do I need to put in their ear before they no longer can confidently hear their tinnitus sound? And very often that's also a low level. And those are both very good signs. Their tinnitus is really not all that loud in terms of its your estimation of loudness, and it's very easy to mask or interrupt the tinnitus. Now, some audiologists that I know and respect also assess residual inhibition at this point. That is, they put the noise that covers up their tinnitus, or the sound, the broadband noise, into the ear for about a minute, and then they ask the patient to tell them when their tinnitus sound comes back. Residual inhibition means that they're not hearing the tinnitus sound even though you've removed the noise, the masking noise. And that's a very positive sign. It tells you if they listen to some soft, pleasant sound, which is interacting with the tinnitus and keeping them from hearing the tinnitus, then at other times during the day they may still not hear the tinnitus even though they're not listening to sound anymore. Now, the only time I will measure loudness discomfort levels is if a patient complains of decreased sound tolerance or hyperacusis. And actually, that happens, in about half of the patients coming in for tinnitus. Okay, now I've mentioned inventories already. Here's the bottom line. You do not want to evaluate a patient with tinnitus and without administering at least one of these inventories. Now, I've got the arrow in this form. This is actually a nice little table from the American Academy of Otolaryngology Head and Neck Surgery Clinical Practice Guidelines. And the arrow is pointing toward the Tinnitus Handicap Inventory. I've been using that since it was first published in 1996, but there are many others now. There's a tinnitus functional index profile, which is excellent. There are many others that are used around the world and in the United States. So I'm not going to recommend a specific. They're all validated. I'm going to say find an inventory that you like to use, that you're familiar with, and then always find out how much the tinnitus is impacting the quality of life. How much is it impacting their emotional response to tinnitus, or how much is it affecting their emotions? How is it affecting their day-to-day activities? How concerned are they about the tinnitus? And you end up with a number that can quantify the impact of the tinnitus on quality of life. All right, now we're going to move right into management. We're getting down to the last 20 minutes or so. And management is obviously critical. You know, you can evaluate a patient with tinnitus, um, but they really want to do something about it. They want to be enjoying life. They don't want to be bothered by the tinnitus. So you need to get into management. But the good news is that even very general, simple, inexpensive, easy to implement management options can be very, very successful. So you don't need to get into very extended, expensive management strategy for most patients. So I'm going to start out with part one of management, focusing on these general recommendations that almost always solve the problem for the patient. Well, I've been emphasizing what I tell patients, what I say to them, how I describe findings, and I'm going to emphasize that again. The more knowledge the patient has, the more I can inform the patient, the more successful my management will be. So as Francis Bacon, very bright mathematician, philosopher, etc., in England, once said, knowledge is power. And so I try to give the patient as much accurate information, I answer all their questions as I possibly can. I want to remove the mystery and the mystique about their tinnitus sound, so now it's just another sound. And I want to do this with not only the patient, but since the tinnitus really affects the whole family, I try to get it for an adult, get the spouse in, and certainly for a child with tinnitus, which is less common, or hyperacusis. I want to make sure I have all the key family members in the room when I'm doing the counseling. And of course, the counseling may not involve just verbal information, but it may be giving the patient written information about their tinnitus. Now, the general management approaches are listed here. The counseling is called directive counseling. This is a term straight out of tinnitus retraining therapy. I don't just say, well, how's the tinnitus affecting you? Oh, so you think you're going to lose your hearing? Oh, I can see why you're concerned. Well, let's talk about that. Oh, that's too bad. That's kind of general psycho counseling. Psychological counseling, but by directive counseling, if a patient says, well, I'm really concerned because I'm going to lose my hearing, I say, well, wait a minute. No, wait a minute. I don't know where you got that idea, but that's not true. I've looked at 2 or 3 hearing tests and you've had in the last year or so. They're all the same. There's nothing in your findings that make me think you're going to lose your hearing. I don't think you need to even consider that. And then when I start talking about the mechanisms of tinnitus, I'm kind of, again, demystifying tinnitus, making it just kind of a symptom, like a sore finger if you or a sore toe if you stub your toes. It's just something that they don't need to really be concerned about, a natural physiologic response. I give them written information. I have little articles that I've written that you're welcome to use. There was one in the Tinnitus Today journal many years ago that patients find very, very reassuring. I've got a few others. And one of the things I also recommend is melatonin, and I'm going to comment more on that in just a moment. It's one of the few over-the-counter substances that actually does improve a person's sleep and reduces their perception of tinnitus. Another very important part of the general management is sound enrichment. That means they always are surrounded by soft sound. If the patient's always around soft sound, whether it's music or sound they download via an app or sound that's coming from a little sound device, then they're not going to notice the tinnitus as much. In fact, very often they don't notice the tinnitus at all. And then, of course, amplification. Hearing aid, if they have a hearing loss of any type, even a mild high frequency loss, will be very helpful because it will amplify environmental sounds, which will then begin to compete with the tinnitus sound. And of course, the environmental sounds are much more interesting than the tinnitus sounds. So that's an important part of the general management for a patient. Now, melatonin has been studied for many, many years. This is one of the earlier articles, 2007, showing that melatonin, which is a very safe substance, we all have it in our blood. It controls our circadian cycle, our sleep-wake cycle. Very, very effective in reducing the perception of tinnitus and helping a patient getting a good night's sleep. And there are many articles, I'm not reviewing all of them, many articles in support of melatonin and also proving that it's safe. So with my strategy, I always encourage the patient stop on the way home from the clinic the day I see them and pick up some melatonin, very inexpensive. Any drugstore or grocery store will have it, and two or three different brands are available, and start taking a pill at night. Usually it's around 5 milligrams per night. Talk to their family doctor, give their family doctor a call, just make sure there's no reason not to take melatonin. There's never a contraindication, but I always like to get the family doctor to approve. And now the patient is actually taking a pill, literally, and they're taking a very concrete step towards solving their tinnitus problem. So there's a placebo effect here in the management, which is fine for clinical work. Placebo effects must be documented in research, but clinically, if the patient thinks they should be getting better because they're taking a pill, which really will help them, and then they actually do get better, that's fine. That's what I want. They're getting better, and that's all I really care about, and we're doing it safely. Now, sound enrichment is critical. Sound device, as you see on the left, they're available a lot of places, $20, $25. The patient picks a sound they like, they put it by their bed or by their where they read in the living room, wherever it's quiet, and they listen to that pleasant sound, very soft in the background. And after a while, they don't even hear the sound, just like we don't hear clocks that are clicking on the wall, we don't hear trains in the distance, we don't hear irrelevant, unimportant background sound. And that's what happens when a person is exposed to these environmental sounds. And if their tinnitus is mixed in with those sounds, which it is, after a while, they won't even notice their tinnitus. Now, there's also a variation of the sound machine called the sound pillow. And I'm going to show you more about that in just a moment in the next slide. But it's a great option because the sound therapy coming through a pillow is almost always providing sound enrichment just when you need it the most, when a patient's in a quiet environment and they want to get to sleep. So the main point here is silence is not good for a patient with tinnitus. Very often patients will seek out the most quiet place trying to get away from the tinnitus, and actually it makes it worse. So they should always surround themselves with whatever sound they find pleasant. So the sound pillow is a great idea, and I've used them for years. Go to their website. I'm not promoting this. I have no financial connection. But it's a very comfortable pillow. Put a pillowcase on it, of course. And the patients put their head down and they can dial in whatever sound that they want to hear as they're falling to sleep. And the beauty of it is, as opposed to a sound device that you put on a tabletop, is only the patient's hearing the sound. So if there are other people around, they're not bothered by it. So I always recommend this. They're not expensive and they're extremely effective in the management of tinnitus. And again, the person's taking a concrete step to solve their problem. Sleep is critical, and we won't get into all of this, but if you can help the person get a good night's sleep, you're well on your way to treating them successfully for their bothersome tinnitus. On the flip side, you can be doing everything possible to help the patient with tinnitus, but if it's still interrupting their sleep, they're not going to make much progress, or at least not very quickly. So go over all good sleep hygiene suggestions, and they're very common. Everybody, you can find them very easily. Here's a list of them. You don't need to be a physician to tell a patient that they need to exercise more and don't drink caffeine after noon, and or eat any chocolates that have caffeine, etc., etc. These are documented strategies for improving quality of sleep, and they're good for your tinnitus patients. As I said, the placebo effect is your friend. So the research shows that no matter what you do with patients, if they think something might help them, there might be up to a 40% of the patients that benefit from this so-called treatment. So in research, placebo is sometimes looked upon as a negative thing. But in clinic, it's positive. In other words, whatever you can do to help the patient improve, and that might just be confidence in you. And of course, you're not going to recommend something that's not evidence based. But if you say this will work, this is evidence based, the likelihood is that this will work with you, most patients will get some benefit from whatever you're recommending. Now, the tinnitus inventory is critical, as I said, And I've used the Tinnitus Handicap Inventory, THI, most of the time. And I've found that just this general management of tinnitus that we've just reviewed, melatonin, good counseling, directive counseling, answer the patient's questions, kind of relieve their concerns about the tinnitus, explain what it's all about, um, recommending the melatonin, as I said, getting the patient to truly follow your sound enrichment recommendations. Those simple steps will have an incredible effect. And in this bar graph, this is for, I've used this over and over now for the last 25, 27 years. I've compared the pre-treatment versus post-treatment tinnitus handicap inventory on these three domains: functional items, emotional, and catastrophic. The catastrophic are, the patient can't escape from the tinnitus. These are the patients who I say yes for the catastrophic questions, who you really are concerned about. They're just about at the end of their rope. They are very, very concerned. And yet, with these simple directive counseling and a few other recommendations, sound enrichment, melatonin, the the levels of these on the scores on the tinnitus handicap plummet. They drop very quickly. The higher the score, the highest score is 100. There are 25 items, and you get 4 points for every yes item on the tinnitus handicap inventory. So you can see here across the board, we're dropping the scores down to the point where the tinnitus is no longer affecting their quality of life. Now, remember, tinnitus is a symptom, and we don't want a patient to have a disease or pathology that's causing the tinnitus without addressing that. So in the interest of time, I'll simply point out that all of these different possibilities must be considered. Although the most common causes for tinnitus are not pathologies, they're disorders: noise-induced hearing loss and presbycusis. So this is where we work closely with otolaryngologists to rule out the diseases and pathologies that might cause tinnitus, and then we focus on our management. As I mentioned, hearing aids are a great option. Open fit hearing aids are perfect for even a person with mild hearing loss. And there's lots of research in support of the benefits of amplification. These are just some of the many studies. And nowadays, and probably for the last 10 years, most major manufacturers of hearing aids have included software that, not just for amplification, but for managing tinnitus. And so whatever hearing aid brand you typically use, they'll have a tinnitus feature. And there's really no good research showing that any one of these tinnitus features is better than the other. The counseling is so much more important than the actual technology. So you can always use this type of sound therapy in any patient getting amplification. And of course, the environmental noise that's being amplified will help the patient tremendously. So anytime you have a patient with any degree of hearing loss, consider amplification. But I never use the word hearing aid. I never use the word hearing aid with these patients. Many have never wanted to use a hearing aid. So I refer to this as a treatment for their tinnitus. This is a tinnitus treatment device. It looks like a hearing aid. It is a hearing aid, but we're not necessarily recommending it as a hearing aid. We're recommending it to help you with tinnitus. And presented in the right way with the right counseling, patients will accept that. Okay, now we're going to get into just quickly, very, very quickly in the next 5 minutes, a little more management, detailed management, more extended management, which is not necessary for most patients. But we always want patients to know that there is always an option for them to be helped. So that if a patient doesn't respond very positively to those general recommendations that I've just reviewed, then of course the next step is, well, we have other options, don't be concerned, and so we're going to quickly review them. One of them is cognitive behavioral therapy, or CBT, and that's mentioned in the AAA, AAO, NHS guidelines that I've already mentioned. Very legitimate. It's a very evidence-based treatment option. Most of the time it's implemented by psychologists, although some audiologists are also including components of CBT in their management. The research on this goes way back to the 1990s, so I encourage you to learn more about it. I've always used psychologists to implement this type of management rather than doing it myself. But it is evidence-based. Um, we don't really have time to get into the details on all these different methods. There are many methods for treating tinnitus. Many of them are very effective. Tinnitus retraining therapy is one, but there are many others. So there always are better options or other options for tinnitus. Diet and lifestyle is very important. I'm just going to emphasize that real quickly. Exercise will always reduce stress and enhance well-being, and that'll help a person with tinnitus. Smoking, there's a direct link between tinnitus and smoking. And healthy diet. The healthier the diet, the less at risk for tinnitus the patient is. I'm just going to quickly go through some of the studies. Here's an excellent study by Chris Spankovich and colleagues showing that the better the diet, the less risk for tinnitus. Here's a study from Korea. Better the diet, less risk of tinnitus. So we don't tend to think of lifestyle and diet when we're talking with patients coming into our clinics, but we should. And this research is very recent and is rock solid. Here's another study, a review study, showing there is a direct relationship between diet, tinnitus, and hearing. So any patient with bothersome tinnitus should improve their diet and, of course, exercise, and they shouldn't be smoking. Another one, is smoking a risk for tinnitus? Well, the answer is yes. This is a systematic review of many studies showing that a direct link. So every patient with tinnitus who is a smoker should immediately be encouraged by not only you but the primary care physician to stop smoking. Now, there are many over-the-counter substances which are purported or are advertised as tinnitus treatments. There are hundreds of them. And the bottom line is the vast majority have no benefit whatsoever. They're not evidence-based, with the exception of melatonin. So I steer patients away from these. Many of them, not only do they not help tinnitus, many of them they're not controlled by the FDA, and nobody really knows what's in them. And so not only do they not help a patient, they may actually hurt a patient. And there are documented reports of patients with tinnitus who are on many prescription medications, particularly elderly patients, who then take some of these over-the-counter substances that people don't really know much about, and they've been fatal. So I firmly discourage the use of these types of so-called treatments with patients because they just don't work, they're expensive, and they may be harmful. All right, well, we're wrapping up. We're at the very end here. You must give every patient with tinnitus hope. As an audiologist, you must say, we can evaluate you with a complete history and a complete assessment. We can develop a management strategy that will help you. Every patient with tinnitus can be helped. They can often get to the point where it's no longer a problem at all. So, in conclusion, tinnitus is a symptom, not a disease. Find out what the disease is if you can. The assessment is quick and simple, half an hour, 45 minutes at most. A single counseling session, some general recommendations which we reviewed will dramatically improve the quality of life for most patients, over 80% based on my experience in the literature. And with the remainder of patients, there are many other options. So there's always hope for the patient. Amplification, tinnitus retraining therapy, etc. Many other strategies. And with appropriate management, patients with bothersome tinnitus can get to the point where the tinnitus is just another sound. And they'll be as happy and as well adjusted and enjoying life as well as they used to before they had the onset of the bothersome tinnitus. And most importantly, they can enjoy a good quality of life. I hope this has been a useful presentation for you, and I truly hope that you consider providing services to most patients who have bothersome tinnitus, that you integrate tinnitus assessment and management into your clinical practice. Thank you.